Welcome back, guys. Today we are going to discuss this important topic following the metabolism of glycogen storage disorders. So let's begin this glycogen storage disorder. So these disorders are group of disorders, okay, that are associated with defect in metabolism of glucose. Defect in metabolism of glycogen. Okay, there is defect in the metabolism of glycogen which leads to this group of disorders. Okay, now these GSTs, okay, are broadly divided into two subtypes. Okay, first is the, remember, liver GST, liver glycogen storage disorder, and the other subtype is our muscle GST, muscle glycogen storage disorder, because the glycogen metabolism takes place predominantly, both the glycogenesis and glycogenolysis, in this liver and muscle along with their enzymes. So these are two types. Under this liver GST, we have this liver GST. This will lead to fasting hypoglycemia. Okay, liver GST will lead to fasting hypoglycemia. Here normoglycemia occurs. Normoglycemia occurs in the muscle GST. Okay, in liver GST there is no exercise intolerance, but in muscle GST there is exercise intolerance. Okay, muscle is exercise intolerance positive, but there is no exercise intolerance in liver GST. Is one of the key facts to remember. Okay, now we will see the types in both the categories. So here we have type 1A. Okay, type 1A is the most common, von Gierke's disease. Von Gierke's disorder. This is the most common GST, von Gierke's disease. Okay, then we have type 1B. Von Gierke was type 1. Then we have type 1B. Okay, and after type 1B we have type 3 GST directly. Type 3 GST. Okay, these are, remember, first is Cory's disease. Okay, then Forbes disease. Okay, then there is limit dextrinosis. Okay, expanding this under this liver GSTs, there is type 4 GST. Type 4 GSTs are amylopectinosis, or is also called Anderson's disease, amylopectinosis or Anderson's disease. Then here after type 4 we have type 6 GST. Okay, 6, skipping the type 5, we have type 6 GST, and this is called Hirsch's disease. Hirsch's disease. Okay, so under the liver GST we have type 1A, 1B, and skipping the type 2 we have type 3, type 4, skipping 5 we have type 6. Okay, Hirsch's disease, type 6, type 4 amylopectinosis, A for A, Anderson's disease, and type 3 GST, Cory's disease and Forbes disease, and also limit dextrinosis. Okay, and type 1 was all important von Gierke's disease, which is the most common GST. Okay, now moving on to muscle GST. Muscle GST is a bit complicated one because it too has its own differentiation. Okay, so let's see what's all the fuss about. Muscle GST is of again of two types. Okay, first is the GST with hypercardiac myopathy, and the other one is without hypercardiac myopathy. With hypercardiac myopathy, without hypercardiac myopathy. So with we have type 2. Type 2 is skipped in liver. Type 2 is here called Pompe's disease. And also Danone's disease, which is not very common. Okay, we commonly discuss Pompe's disease. Also there is Danone's disease, but this is not very common. Okay, here without hypercardiac myopathy we have skipped the type 5 there. Here is type 5. This is McArdle's disease. And then type 7 GST, type 8 GST, okay, also called Tarow's disease. It's type 5 and type 8 are without hypercardiac myopathy. Only type 2 is with cardiac hypermyopathy in the muscle GSTs. Okay, the feature is exercise intolerance. Okay, type 8 is Tarow's disease. So this was the classification here. Okay, now start with our discussion on each one of the GST. Okay, so first one is type 1 GST. Okay, which is a bone gear case disease. Okay, this is the most commonly occurring GST. Okay, most commonly occurring GST. What is the biochemical defect here? Biochemical defect. The defect is G6 phosphatase. In glycogenolysis in liver, and gluconeogenesis. We have discussed glycogenolysis and gluconeogenesis in the previous lectures. Go check on that out. The defect is in G6 phosphatase. Okay. Now the biochemical hallmarks. Okay. First will be fasting hypoglycemia, a feature of liver GSTs we've seen in this classification. First will be fasting hypoglycemia, then will be followed by lactic acidosis, which will be followed by ketosis, followed by hyperuricemia and hyperlipidemia. These are the 5 hallmarks of the von Gierke's disease or type 1 GST. So we'll see the steps by which these defects occur. Okay, so here we have our glycogen. Okay, now glycogen phosphorylase act here, which converts it into limit dextran. dextran. Okay, now what is this limit dextran? This is glycogen with short branches. Glycogen with short branches. This is limit dextran. Okay, now upon this acts as the debranching enzyme. Debranching enzyme and gives the product. We don't have a specific name for the product, just we are having the product. Okay, now this product, okay, is actually a reversible process. This product actually goes to the glycogen phosphorylase. Okay, from here okay, we form G1 phosphate. Okay, now G1 phosphate through mutation enzyme we form G6 phosphate. Okay, and finally from G6 phosphate we have our glucose 6 carbon. Here in this step we know that G6 phosphatase acts, and we know in this defect, this is the defect here, G6 phosphatase does not act here. So what will happen? G6 phosphate will start to accumulate, and what will happen following the accumulation? Glycogenolysis occurs, leading to typical fasting hypoglycemia. Glycogenolysis occurs, fasting hypoglycemia occurs, which is very severe. Okay, now following the G6 phosphate accumulation, this G6 phosphate, okay, this enters our HMP pathway. We will discuss HMP pathway later. A hexose monophosphate pathway, one of the pathways in the carbohydrate metabolism in our body, HMP pathway. This HMP pathway actually forms pentoses, 5 carbon substances, so there will be increased pentoses, and these pentoses are required in the formation of our nucleotides, that is our purines. So there will be increased purines, and these purines on their metabolism and breakdown forms uric acid. This will lead to our typical hyperuricemia that we have discussed in the hallmarks of von Wieck's disease. Okay, increased uric acid will lead to hyperuricemia through the HMP pathway. Okay, now moving on, this accumulation of G6 phosphate, okay, this will go on to synthesis of pyruvate, okay, through glycolysis. Okay, pyruvate will be synthesized. Okay, now this pyruvate have two fates. Okay, have two fates. First fate of pyruvate is it will form lactate, which will lead to a hallmark lactic acidosis. Very simple. Okay, the other fate is formation of acetyl CoA in TCA cycle. Pyruvate enters the TCA cycle to form acetyl CoA. Okay, this acetyl CoA will lead to two pathways. Acetyl CoA enters the TCA cycle, okay, or it goes to ketone body synthesis. We will see ketone body synthesis in lipid metabolism. Remember, acetyl CoA is one of the substrate or entry products for ketone body synthesis. Ketone body synthesis or TCA cycle. Now this TCA cycle does not occur. due to higher due to decreased level of oxaloacetate. Decreased level of oxaloacetate. Why? Due to high gluconeogenesis. High gluconeogenesis. Due to high gluconeogenesis, oxaloacetate level is depleted. So TC cycle does not occur, and instead ketone body synthesis occurs. This will lead to ketoacidosis or ketosis, ketoacidosis and lactic acidosis. These are the one of the hallmarks. Okay. Now we've seen the acetyl CoA. This acetyl CoA on formation, this enters the fatty acid synthesis pathway. Fatty acid synthesis pathway. This leads to increase in triacylglycerol level. Okay, triacylglycerol level increases, and very simply it leads to hyperlipidemia. Hyperlipidemia. Okay, so it's in the 5 hallmarks: hyperlipidemia, ketosis, lactic acidosis, hyperuricemia, and fasting hypoglycemia. Okay, now the clinical features. Clinical features of von Gerke's disease. First is in children. Okay, there will be chubby cheeks and thin extremities. Chubby cheeks along with thin extremities. This represents doll-like faces. Doll-like faces with chubby cheeks and thin extremities in children. Okay, the primary feature. Then we have hepatomegaly leading to protrusion of abdomen. Okay, following hepatomegaly we have rhinomegaly, which will lead to increased fat deposition, and one important feature is there is no splenomegaly. Okay, hepatomegaly and rhinomegaly, but no splenomegaly. Okay, and there are features of hypoglycemia. Okay, now how will we investigate? Investigation of type 1 GST. We are suspecting it a type 1 GST. How will we investigate? Very simple. There will be increased lactate, increased uric acid, decreased glucose, increased ketone bodies, and increased triacylglycerol. Okay, you can do simple. These all findings can be found by IV intravenous glucagon challenge. IV glucagon challenge will, if it leads to these following features, then we'll diagnose this as type 1 GST. Okay, so this is all about von Gerke's disease and all the pathways involved. Okay, enzyme efficiency G6 phosphatase. G6 phosphate accumulating will lead to all these hallmarks. The clinical features, remember, no splenomegaly, and these are the investigations to be done through IV glucagon challenge. Moving on, we have type 2 GST or type 1 BGST. That was type 1A and 1B. What's the difference between these two? It has all the features of type 1 GST, okay, along with neutropenia, okay. And there is neutropenia, which means decreased level of neutrophils, which is the cause of recurrent bacterial infection. This is the cause of recurrent bacterial infection. So type 1B GST. So all the features of type 1 GST along with neutropenia. So we see a patient coming with recurrent bacterial infection. We do the test and diagnosis. We found that it has type 1 GST and also found there is decreased neutropenia. So we diagnose this as type 1B GST. Now we have, skipping type 2, we have type 3 GST. And what was this called? Limit dextrinosis or Forbes disease or Cory's disease. Cory's disease or Forbes disease or limit dextrinosis. Cory's disease or Forbes disease or limit dextrinosis. So what happens here? First is the biochemical defect. So biochemical defect is in the debranching enzyme. So in the steps we have seen glycogen being acted upon by glycogen phosphorylase led to formation of limit dextrin. We have seen limit dextrin, which is acted upon by our debranching enzyme. Debranching enzyme which will fall to our product, that is alpha 1,4 linkage product. This is our product. This product is again going back and getting acted upon by glycogen phosphorylase. So the defect is here, debranching enzyme defect is here, and limit dextrin accumulates. Very simple. That is why limit is type 3 is limit dextrinosis. Now clinical features. There is fasting hypoglycemia, obviously it's a liver GST. Fasting hypoglycemia, hepatomegaly, okay, so protruding abdomen, okay, very common findings, protruding abdomen. Now there is splenomegaly, but no renomegaly. There is splenomegaly, hepatomegaly, but no renomegaly. Okay, one of the feature here. And there is micronodular liver cirrhosis. Okay, this is one of the features questions asked in questions relating to type 3 GST. Okay, so how will diagnose this? The diagnosis: there is no increase in lactate and uric acid. there is no increase in lactate and uric acid. Ketosis happens. Okay, liver enzymes are elevated. Liver enzymes are elevated. What are the liver enzymes? LT, ST that we commonly test. Liver enzymes are elevated. Okay, these are done through again IV glucagon challenge. IV glucagon challenge. Okay, this was type 3 hemodextrinosis or Courage disease or Fox disease, defect in the D branching enzyme. Moving on, we have our next GST to discuss, type 4 GST. Type 4 GST. Okay, this is called Anderson's disease. Anderson's disease, or A for amylopectinosis. Amylopectinosis, Anderson's disease or amylopectinosis. So what happens here? The biochemical defect. Biochemical defect is, so there is this glycogen produced in glycogenolysis. So there is glycogen which is acted upon by UTP glucose polymers, okay, to form alpha 1,4 linkage glucose polymer. Okay, this takes place in glycogenesis steps. Okay, alpha 1,4 glucose polymer, and here the branching enzyme acts here. Okay, and finally glycogen is formed with alpha 1,6 branches. We know linkages are alpha 1,4 and branching are alpha 1,6 in glycogen. Okay, the defect is here. Again, this branching enzyme defect. Okay, branching enzyme does not act properly, so this will lead to, the defect will lead to abnormal glycogen accumulation. Abnormal glycogen accumulation. Very simple. The branching enzyme is defect here. Remember, branching enzyme, not debranching enzyme. It's a branching enzyme. In the steps here are glycogenesis. Glycogen is being formed. So branching enzyme is defect here. So abnormal glycogen accumulation. This abnormal glycogen accumulation here, amylopectin-like, so called amylopectinosis. Okay, amylopectin-like, so are called amylopectinosis. Now the all important diagnosis. Okay, it's a fatal condition. First is, it's a fatal condition. Okay, next is hypoglycemia. Okay, following ketosis. There is, we have discussed the progressive micronodular liver cirrhosis. Progressive micronodular liver cirrhosis is present. This leads to, remember, this leads to portal hypertension. portal hypertension and esophageal varices. Esophageal varices. Portal hypertension and esophageal varices, that is the portal veins related to the liver near the esophagus. The esophagus gets ruptured and leads to bleeding. The esophageal varices. These two lead to liver failure and ultimately death. Liver failure is a progressive disease because cannot be undone. It gets progressed and will ultimately lead to death. This is why it's a fatal condition with hypoglycemia and ketosis. Remember, macronodular liver cirrhosis, progressive macronodular liver cirrhosis. Okay. The other features here are no lactate and uric acid increase. There is no lactate and uric acid increase. Okay, and increase in liver enzymes. Obviously, the liver cells get damaged, the enzymes escape to the blood and they are detected on tests. Especially remember transaminases, ALTs and ASTs. Okay, and there is abnormal glycogen. Obviously, these are amylopectin like in electron microscopy. Amylopectin like in electron microscopy. This was fatal condition of type 4 GST, Anderson's or amylopectinosis, defect in branching enzyme. Okay. Progressive macronodular liver cirrhosis will lead to the fatal condition, portal hypertension and esophageal varices. So moving on, next we have we have type 4, we have type 6. Okay, type 6 GST or last in the liver GST discussion, also called Hirsch disease. Yeah. How I remember, after the letter H, the biochemical defect, is H for H, hepatic glycogen phosphorylase. Hepatic glycogen phosphorylase. So H for H, hepatic glycogen phosphorylase. Okay. Now very simple, this glycogen phosphorylase action acting upon glycogen to form filament dextrins. So the effect is here and glycogen accumulates. Okay, the features here, it's not a very common GST. The feature here is gluconeogenesis is intact. Gluconeogenesis is intact. Okay, the other is hypoglycemia is there. The rest of the features may present, may or not present, but hypoglycemia will be there, which is not very severe. Okay, not very severe. So this was our type 6 GST Hirsch disease. H for H, hepatic glycogen phosphorylase. Okay, gluconeogenesis is intact is the feature here. So this was all about a discussion on liver GSTs. Now we will be moving on to muscle GSTs. Okay. Muscle glycogen storage disorders. Okay. So let's begin with our first muscle GST. It is our Dannon's disease. Dannon's disease. Okay. Dannon's disease. This is a defect in lysosomal associated membrane protein 2. These are LAMP2, lysosomal associated membrane protein 2, defect in LAMP2. Okay, not much to discuss here, just to know the defect is in LAMP2 here in Danon's disease. Okay, next is our type 2 GSD, Pompe's disease. Under type 2 we had two diseases, Pompe's disease which was the main, and Danon's disease, not much discussed. Defect is in LAMP2. Type 2 disease, Pompe's disease. Okay, it's a lysosomal storage disorder. In muscle GST, it's a lysosomal storage disorder. Okay, the enzyme defect is our alpha 1416 glucosidase, or this is also known as acid maltase. Remember, this is a bifunctional enzyme, alpha 1416 glucosidase. So it's a part of the bifunctional enzyme in the glycogenolysis. Okay, the enzyme defect is here. So the clinical features, this will have in the children, there will be feeding difficulties, okay, and children failure to thrive, okay. There is hypotonia, muscles hypotonia, leading to characteristic floppy infants, hypotonia leading to floppy infants, and cardiomegaly, this causes death at around 2 years. Very early the children dies at around 2 years due to cardiac failure, not enough pumping of the blood, and failure of development of heart. There is death at around 2 years of age in the type 2 Pompe's disease, which is a lysosomal storage disorder. Okay, lysosomal storage disorder. Okay, there is hypotonia, floppy infants, and cardiomegaly, which leads to death at around 2 years. These are the important clinical features. Now the investigation in children, if we suspect, what investigations to be done? First is X-ray to detect cardiomegaly. Normally in children, when we don't find anything, we do X-ray to find if there is problem in the heart. Then there is serum creatine kinase. This enzyme is elevated in myocardial infarction, so this enzyme will be elevated. Then will be serum AST, liver enzyme will be elevated, and serum lactate dehydrogenase, another liver enzyme, will be elevated. These all three enzymes will be elevated. Okay, and then there is, we'll do the X-ray to detect cardiomegaly. These three enzymes will be elevated. Moving on, in the muscle GST, we have type 5 GST, which is our McArdle's disease. McArdle's disease. Okay. Now this is the first point, is the most common muscle GST in adolescents. Harper says this line, this is the most common muscle GST in adolescents. Okay. Now the biochemical defect. Muscle glycogen phosphorylase. Glycogen phosphorylase. Okay. Now the clinical features. As the muscle GST, there will be, first of all, in the adolescents, exercise intolerance. In the classification we have discussed, exercise intolerance is one of the key features of muscle GSTs. Exercise intolerance is called second wind phenomenon. Second wind phenomenon. So what is the second wind phenomenon? So during exercise, pain arises in the muscles. Pain arises in the muscles. Okay. So we rest for some time. We rest for some time. Lead to pain decreasing. Pain decreases and we do more exercise with ease. Very simple phenomenon, nothing complex. Exercise with ease. This is the second wind phenomenon. Okay. Now another clinical feature here is rhabdomyolysis. Rhabdomyolysis. Okay. What is this? There is myoglobinuria. The myoglobin protein in the muscle comes in the urine. It gives a characteristic burgundy colored urine. Myoglobinuria leading to burgundy colored urine. Okay. So this was all about McArdle's disease. Most common point is most common muscle in the adolescents, exercise intolerance, and there is second wind phenomenon. Okay. Also all important, myoglobinuria. Okay. Moving on with the type 7 GST. Type 7 GST. Okay. Also called as Tarwi's disease. Tarwi's disease. Biochemical defect. Biochemical defect is muscle and erythrocyte, muscle and RBC phosphofructokinase 1. Phosphofructokinase enzyme of glycolysis. There is muscle and erythrocyte phosphofructo 1 kinase 1 deficiency. So in the muscles, this will lead to exercise intolerance. Okay. Myoglobinuria into burgundy colored urine and no second wind phenomenon. Okay, this is one of the difference. No second wind phenomenon. There is no second wind phenomenon here in type 7 GST Tarwi's disease. And erythrocyte PFK1 is defect led to hemolysis. Very simple understanding, hemolysis and these three features in muscles: exercise intolerance, myoglobinuria, and no second wind phenomenon. This was all about our discussion on glycogen storage disease. Very important discussion, very clinically relevant topic. We will also we discussed in our second year professional in pathology. Here we have seen the liver GSTs and muscle GSTs and their clinical features and the biochemical defects. What are the hallmarks of various diseases? So please do revise them, guys. Thanks for watching. I will catch you in the next one. Good luck.